for those who are joining us again, welcome. And those who are also new to these webinars, I also do welcome you. Today, or this evening, we have Stephen Ling, who I will get him to introduce himself a bit more in a second, but we'll be focusing on a discussion and clinical cases around the role of SafeScript New South Wales. As many of you are aware, SafeScript New South Wales can be used for lots of different avenues of clinical care. In this case, we'll be definitely focusing on OAT and opioids as well, considering that these clinical case webinars are under the OTAC banner. But before I do go any further, I would like to make an acknowledgement of country. I would like to acknowledge and pay respects to the traditional owners on the lands of which we meet this evening, wherever we are joining. This evening I'm on Wungal and Gadigal land, and I extend this acknowledgement to all the lands on which we are meeting this evening, and pay respect to elders past, present and emerging. As always, I'd like to present a little bit of a breakdown about who's registered for this evening. It always just helps remind us who's joining us. And the sort of metropolitan to regional mix doesn't often change too much. It's very often we have 60% from metropolitan sort of regions, and about 30 to 35% within regional areas. So wherever you are coming from this evening, welcome. I also thought I would highlight sort of the top three roles of health professionals who are joining us this evening. And in gold position is pharmacists. So welcome to any pharmacists who are joining us. But we also have some really good numbers from people in various nursing roles, as well as general practitioners. So but whoever you are, nonetheless, welcome. I think that's probably all for me now in terms of introductions, and I'm going to hand over to Stephen and he can introduce himself, and we can get started. And just a reminder as well, feel free to always use the chat functionality, and at appropriate times of discussion, we very much encourage you to unmute yourself as well. Thanks, Stephen.
Thanks, Daniel. So I'll just share my screen and take over. Hopefully that's coming up now. And I'll skip through the first couple of slides because Daniel has already presented those. So hello everyone, and welcome to our discussion this evening on the role of SafeScript New South Wales with opioid agonist treatment. And thank you to Daniel and the OTAC team for inviting us to present. We did want to start off with a live poll this evening. So what I would just like people to think about for a moment is, are you using SafeScript New South Wales in particular? And whilst you're doing that, if you could think about what your biggest challenges or concerns with the system are, and in addition, what are the things you find most useful about the SafeScript New South Wales system? So I'll just give everyone a moment to respond.
Got about 65% of people who've responded, so I'll give it a few more seconds.
And the results are coming back with around 2/3 of people dialing in this evening are using SafeScript New South Wales. Just under 25% are not, and another 12% are unable to access SafeScript New South Wales because they are not deemed eligible. Thank you for that, Daniel. So I would also like to begin by acknowledging the traditional custodians of the lands on which we are all meeting tonight, and pay my respects to elders past, present and future. I extend that respect to Aboriginal and Torres Strait Islander colleagues who are joining us this evening as well. Our agenda for this evening will include an overview of SafeScript New South Wales. We will provide you with information on education and support strategies which have been developed to assist you in your clinical practice. We will then run through a number of case studies designed to highlight circumstances in which SafeScript New South Wales might be useful in assisting your clinical decision making, and we will finish off with some final questions and answers. So we'll move to a broad overview of SafeScript New South Wales. SafeScript New South Wales is a real-time prescription monitoring system that provides prescribers and pharmacists with access to a patient's prescription history for high-risk medicines such as opioids and benzodiazepines. Information is collected via the prescription exchange services and stored in the SafeScript New South Wales repository, so that prescribers and dispensers who are using integrated clinical software will receive notifications to warn them when a high-risk situation has been detected by the system. A patient's history can also be directly accessed through the SafeScript New South Wales portal. Access to this information helps in making safer clinical decisions about your patient's care. The system does not instruct you on what to do. It provides additional information and context to support discussions with your patients. In terms of registration and use of the system, since the statewide launch of SafeScript New South Wales in May 2022, uptake of the system has been positive, with around 45% of AHPRA-registered prescribers signing up to the system, and that includes 65% of AHPRA-registered general practitioners and 68% of AHPRA-registered pharmacists. In addition, 55% of addiction medicine specialists, 67% of pain medicine specialists, 40% of psychiatrists, and 35% of eligible nurse practitioners have registered for SafeScript New South Wales. And the program team have received some feedback from practitioners who have been using SafeScript New South Wales. One practitioner described this as providing better visibility, more informed interactions with patients about harm minimisation. Another commented that a multidisciplinary approach where both prescriber and pharmacist are using SafeScript New South Wales is important. And SafeScript New South Wales allows practitioners to have visibility of prescribing and dispensing practices of other practitioners. Now, we do want to stress for a moment the importance of data. Correct and complete data entered into prescribing or dispensing systems is vital to ensure the accuracy of information available to SafeScript New South Wales. And a variety of education and support strategies have been developed to assist health practitioners in their use of SafeScript New South Wales. In addition to e-learning modules that are available on the SafeScript New South Wales website, there are a number of new resources to help use the system. There is now a patient brochure to facilitate and support conversations with patients about SafeScript New South Wales, and also a clinician brochure specifically on responding to notifications and alerts in SafeScript New South Wales or to a patient's history of concern. There are now a number of quick reference guides on registering and logging into the system, on pop-up notifications and alerts themselves, and other guides on key functionality of the SafeScript New South Wales system. Vitally, there is a clinical advice line. I'll just skip back to the previous slide there. The clinical advice line is a dedicated telephone clinical advice line to support primary care providers, including facilitating access to clinical advice for addiction medicine, pain management, and mental health, supporting safe de-escalation of high doses of monitored medicines, guiding appropriate management and referral to other clinical services where required. And this brings us to the first of our case studies. Our first patient is Janet. Janet is a 44-year-old woman. She is a patient of a retired colleague in your practice. She presents saying, "Dr. Smith has prescribed OxyContin for me for years." You see in the notes that she has been prescribed OxyContin 40 milligrams twice a day for the last 6 months. This was initially commenced at a lower dose in an emergency department following a presentation with extensive superficial abdominal burns around 3 years ago. She has been attending the same doctor and pharmacy regularly for her prescriptions. She has no other prescribed medications. She does have a previous history of postnatal depression. She's a non-drinker and a non-smoker, and she has no other health concerns. She has, however, generated a red alert in the SafeScript New South Wales system for a high-dose OMED above 100 milligrams daily. So I'd just like people to take a moment just to consider, what does the high-dose OMED mean in this context? And what approach should we be taking with Janet at the moment?
And just a reminder as well, if you want, you can either use the chat function, but if someone also wants to unmute themselves, more than happy. Oh, and we've just got a question coming through, Stephen. What does OMED mean?
Okay, so
Yes.
OMED means the oral morphine equivalent dose of an opioid. So in this context, Janet is taking 80 milligrams of OxyContin a day. Would anyone like to hazard an estimate of what that means in terms of an oral morphine equivalent dose? So a couple of people have typed in 120 milligrams, and I would agree with that estimate. There is another comment that requesting information on whether or not she is doctor shopping. I tend to steer clear of the doctor shopping term. I prefer to use accessing multiple prescribers for medicines. I think it's a more accurate description of what people do. She is not accessing other prescribers for her prescriptions. She has only been seeing the one prescriber. Any other questions or comments very quickly? So if we take a moment just to consider, so Janet has generated a high dose alert for a high OMED, over 100 milligrams of morphine equivalent daily. Can we get a sense from people whether or not anyone feels that Janet requires opiate treatment at the moment in the form of either methadone or buprenorphine?
And I've just started a poll on that question. So you can either say yes, no, or unsure if you don't think you have an answer for this question in particular.
So we're receiving a variety of responses, and it's almost working out a third each way by the look, Daniel.
Yes, yeah, that's very interesting. We've had about 70% of people respond, so I'll end it at 75. We reach there.
So 36% are saying yes, 39% are saying no, and about 25% of people are unsure. So for me, I think there are a number of other strategies that can be applied in Janet's case before we would move on to something like methadone or buprenorphine. So the high dose alert alone for me would not be sufficient to start a discussion around methadone and buprenorphine at this point. I would think that a dose de-escalation or a dose reduction over a period of time and a discussion with Janet around that would be a more appropriate approach at this point. Also considering her history of postnatal depression, what her mental health may be currently. And in addition to that, I would also be exploring with her other strategies to better manage pain without the requirement for opioid medications. There are some comments coming through. Janet has tolerance, but we don't know about other features of her dependence, if at all. And a further comment, there is no way in the world this woman is drug dependent in terms of the act, and I would agree. So we'll move on. Our next patient is Abdul. Abdul presents saying, "Hi there, I just need my oxys." He is a 45-year-old man. He's well known to you. He's being prescribed OxyContin 30 milligrams twice a day for severe osteoarthritis of both knees and hips. He has a past history of chronic lower back pain and chronic insomnia. And on accessing SafeScript New South Wales, you see the following in Abdul's history. So he has generated notifications for a red alert for 4 prescribers at 4 different practices in 90 days, a red alert for an OMED over 100 milligrams daily, and an amber alert for accessing more than 4 pharmacies in 90 days. And if we consider the 60 milligrams daily of OxyContin,
Let me finish this one, I'm busy.
that alone would not breach the 100 milligram daily OMED rule. And so when you access SafeScript New South Wales, you see the following in Abdul's history. He is prescribed endone 5 milligrams PRN for breakthrough. He receives 60 tablets a month for that. He's also receiving Panadine Forte, 150 tablets a month. He's receiving diazepam 5 milligrams at night, 50 tablets a month. Pregabalin 75 milligrams twice a day, 56 capsules a month. And the OxyContin we've previously mentioned, 30 milligrams BD, 56 tablets a month. But in addition to your prescribing, you also see that he's accessing OxyContin 30 milligrams twice a day, 56 tablets a month from 2 other prescribers. And we've mocked up a couple of different scenarios for Abdul for you to see how a rolling OMED might work. So the rolling morphine equivalent daily dose is generated over a 90-day period. So once a day ticks over from the 90 days, if the dispensing of the medication is not within that 90-day period, it is not included in that previous 90 days. So if we look at Abdul having 1 prescriber for 3 months, but additional OxyContin from 2 other prescribers over a 1-month period only, the rolling OMED over that 90-day period is something around 174.5 milligrams daily. If, however, he was receiving those medications from the 2 other prescribers over the entire 90-day period, his OMED would be approximately 286.5 milligrams daily, so quite a significant difference there. So we probably need to just go back just for a moment, sorry, and think around the same questions that we thought about with Janet. So if we raise those same questions, does Abdul require OAT? Do we have a sense from people in the audience? Any ideas? There are a few people saying yes. Likely yes. Very good comment. Is he selling the medication on? And certainly from my way of thinking, I would be holding a discussion with Abdul about methadone or buprenorphine and explaining to him that it would be unsafe to continue prescribing under these circumstances. Our third patient is a patient who is already on oral methadone. Bob is a 38-year-old male. He attends for a clinical review. He has 85 milligrams or 5 milligrams per 1 ml oral methadone daily with 3 supervised and 4 takeaway doses each week with no more than 2 consecutive doses at a time. And you check SafeScript New South Wales and there is no record of prescribing or dispensing transactions for any monitored medicine or for methadone. Does anyone have any idea why that would be the case? Prescribed through a public clinic? Absolutely. Could be interstate. And so what we find with SafeScript New South Wales, if we recall some of the information about SafeScript New South Wales, the system obtains its information from the prescription exchange service, which requires prescribers or dispensers of medication to enter that transaction into integrated clinical software. Most public and private methadone and buprenorphine clinics do not use integrated clinical software. So either one or the other or both, the prescriber or the dispenser, need to be using integrated clinical software for methadone or buprenorphine to be captured as a transaction in SafeScript New South Wales. There are a couple of questions coming through. Will there be a national SafeScript? And I think the best way to respond to that question is that we do now have interstate access to many of the systems, and interstate prescribers and dispensers can access information in SafeScript New South Wales, so long as they are treating a patient of New South Wales or are being consulted about a patient in New South Wales.
And Stephen, just to follow up on that, in your experience, what about if someone who's in New South Wales wanting to access interstate records, assuming they are a prescriber or providing clinical care? Generally, do we find other states allow that?
That's variable, Daniel. Thanks for the question. We find that that's variable. I would think that the best approach would be to access information from each individual jurisdiction. So each website should have information on how you could access information from their systems. But certainly from the New South Wales perspective, we have allowed interstate prescribers and dispensers to access information from our system.
Wonderful.
Our final patient for this evening is Julie. Julie is a 56-year-old female. She has a history of chronic non-cancer abdominal pain. She is on Suboxone film, 18 milligrams daily. She receives no takeaway doses due to ongoing instability. You check with SafeScript New South Wales, which reveals Suboxone film 18 milligrams sublingual daily under your prescription. But she's also receiving Endone 5 milligrams, 20 tablets prescribed each week by another GP. She has dispensing transactions for those weekly prescriptions every 4 to 5 days over the last couple of months. She's been receiving diazepam 5 milligram tablets, 50 tablets to be taken orally 2 twice daily by the same GP who has been prescribing the Endone. And again, the dispensing transactions reflect dispensing every 8 to 9 days for the last 2 months or so. How would people approach Julie's situation? Do we have any takers? So we have a comment, inform the Endone GP. He's breaking the law for a start. I like that. Is she taking the Suboxone? Speak with both the patient and the other prescriber. Any further comments? And so ultimately for me, this is about safety. And that's there's a comment coming up that the endone won't have much effect due to the antagonist effect of the buprenorphine. And whilst that's true, it does increase the risk of harm to Julie. So I agree. I think the approach should be to discuss with the other practitioner the safety of this, or the unsafe nature of the situation, particularly with the prescribing of additional opioids and benzodiazepines in the context of Suboxone film. But it's also important to discuss the situation with Julie and trying to get a sense from her what's happening from her perspective, but also explaining to her the situation under which you're prescribing the Suboxone film for her and the unsafe nature of the additional medications. So engaging the patient and educating them, discuss the situation with the other prescriber, yes. So I think we've covered most of that there. Which brings us to the question and answer part of the evening. Now I'm going to just quickly switch off from this slide because the next slide that we have does have those additional resources that can be useful when people are using SafeScript New South Wales. So do we have any questions?
Yeah, Stephen, Dan Ewald here, Far North Coast, New South Wales. I'm surprised that the proportion of pharmacies and prescribers that are enrolled is so low. Why do you think there's such resistance?
Thanks, Dan. And that's a very good question. And I'm not sure that we can really answer it. I don't think we have the answers. It may be that there is a degree of confidence with what they are doing, what they're seeing with their patients. But ultimately, it's probably not a question we have an answer to currently. Is SafeScript looking into other software like Helix? I'm not sure that I'm the person to answer that. I'll leave that to others. And there is data on prescribing and dispensing patterns, yes.
Stephen, a question that I sometimes get is, obviously we were discussing before that, for instance, public services, they won't generally be included on the SafeScript New South Wales system because they're often not using compliant software. I know there were some discussions that with the S100 changes that might be possible, or there might be potential avenues in the future for OTP scripts that are dispensed or prescribed in the public setting to be on SafeScript. Are there any sort of plans for that in the future?
Look, again, it's not something I'm aware of necessarily, Daniel,
Yeah.
but I have to say that recently, just my personal clinical experience, I'm finding that at least dispensing events for methadone and buprenorphine are becoming increasingly visible on SafeScript New South Wales. So I think that may be happening just naturally over time.
Yeah.
Stephen, could you just summarize for me all the ways that prescribing can be happening that SafeScript will miss?
I'm not sure that I could capture all ways, but largely it's any system that doesn't use integrated clinical software. So handwritten prescriptions, for example, won't be captured. Public and private clinics that aren't using clinical clinical software that is integrated won't be captured. But as I said previously, so long as either the prescriber or the dispenser is using integrated clinical software, it will be captured by SafeScript New South Wales.
So it captures DVA and it captures private scripts if they're written on integrated software or dispensed with integrated software.
Yes.
And quite a lot
so
of pharmacies are still not using integrated software for dispensing.
Some don't, that's right.
Okay, thanks.
So I do have a bit more information here. So the registration statistics are based on AHPRA registered practitioners. We do expect there are many who are still registered with AHPRA, but do not practice any longer, and therefore they have no need to register for SafeScript New South Wales as well. So that's a bit of a gap in the information that we have.
And it includes all the rheumatologists and things, or the cardiologists that might have pretty low interest.
That's right, exactly. And there is a comment, nearly all pharmacies would be using integrated software, and that's true. Whether or not they use it for methadone and buprenorphine, however, isn't so clear. And I guess that may be where certainly I'm starting to see with those PBS changes, whether that has influenced the entering of that transaction into clinical software. But I'm only guessing.
Frank, I can see you've raised your hand. Did you have a question or query?
Yeah, thanks, Dave. It's more a comment. I use best practice, and my clinical practice is 100% addiction, and most of that, of course, is OAT. I find that the only way I can practically work in a session is to turn off the prompts inside my software and have SafeScript on a tab on my browser. Because every time everything I write is either an S8 or an S4, every time this happens, of course, the software interrupts me. And so I turn it off and I have the tab open. Usually I check it at the end of the day, or if there's something relevant to the patient at the time, I'll click it. But I think it's a really good thing to be aware of, this, in my mind, the efficiency of having the tab open all the time on your browser while you're working. But I think having the software prompt you is an absolute handicap to your working day.
Oh, look, thanks for sharing that, Frank. And I think it's really important that if you've been able to develop a workaround for yourself, that sharing that with colleagues here this evening has been really important as well.
Stephen, can I make a comment? So I'm a GP addiction medicine specialist in Hornsby. With the introduction of SafeScript, which, you know, seemed like a really good idea, it had to be installed 3 times and deinstalled 3 times and then reinstalled. The whole process took about 3 months. And, you know, I'm operating in the bulk billing space. My staff and managers highly stressed. We've got a very large number of government operations surveying our data and slowing our computers down. So, you know, this is a great system, but in the pharmacy and general practice space, we're very highly stressed and we're highly disgruntled, and becoming more so, particularly in the pharmacy space. So, you know, good ideas, but look, you know, a lot of us are at the point of saying, well, look, we don't really care.
Sure, thanks, John. Any other questions or comments?
I think it's the best thing since sliced bread.
And so hopefully what we've been able to show this evening, 4 different scenarios that really show how SafeScript New South Wales can be helpful within the OAT space. So it gives you visibility of a patient who is complying with the care that you're providing. There are no issues, and the patient probably just requires a little more discussion around where to from here with their opioid medications. We've provided a case study where there is a patient who is using high dose of opioids. They're accessing those opioids from multiple practitioners. And in that case, the patient most likely does require a discussion around OAT. A third patient who is already on OAT, where SafeScript New South Wales has shown that there are no other issues for that patient. They're quite stable on their treatment. And a fourth patient who is on OAT, where there are problems where other medications are being prescribed, the patient isn't being upfront with you, and you're able to have visibility of what is happening for that patient through SafeScript New South Wales. Do we have any final questions?
I think we might have all questions answered in this case.
Which means, I guess, Daniel, we'll finish a little early.
Nothing wrong with that at all. I'm sure we're all keen to have dinner or... Oh, wait, did we have a question? I think I heard someone in the background.
Well, look, I'd like to thank everyone for attending, providing us with an opportunity to discuss SafeScript New South Wales and how it might assist with opiate treatment with methadone and buprenorphine. And I wish you all a good evening and hand you back to Daniel.
Wonderful. Thanks so much for that, Stephen. And don't forget as well, check out the resources on the SafeScript website, as well as that clinical advice line that was just up on the slide. When we flick around the email afterwards, we'll make sure we include, a couple of key resources and things like that. Other than that, we are looking forward to our next session, which should be in mid-September. I'm hopefully going to be able to announce the topic in a few days' time. We had to chop and change a bit. But I can let you know that we do have our October and November sessions lined up. October is actually looking at chronic pain with OAT. And so some of you might remember that we did have an acute pain discussion just last month. So hopefully that will help complement that discussion. And the November session, we are looking to examine QT prolongation, sort of those issues at hand, how to identify them, the issues, and how to manage that within patients. I think just before we do go, and I'll just quickly share my screen, just a very quick reminder as well that we do have on the website this clinical case webinar session page, and here we provide updates on our latest topics that we are looking to discuss. As you can see, it currently says the session that we're currently in now. We're always happy for you to submit a case or a suggested topic, by all means. And as always, we do provide recordings at the end, as well as the lecture slides that you can download, as well as specific sections within the OTP guidelines as shown, and even sort of other resources. So at the last session, when we were looking at acute pain, we did a sort of overview that S8 application for pain management form. So we've included that there. But otherwise, I think we will end a little bit early. And thank you for your time, everyone. And once again, Stephen, thank you very much for joining us this evening.
Thank you, Daniel.
Have a good night, everyone. Bye-bye.